Hello, everyone. My name is Chanel Blackwood, and I am the marketing manager at HAHIA. Welcome, and thank you for registering for today's workshop, Preferences for Adjuvant Immunotherapy in Resected Stage 3 Melanoma. Today's webinar will run for approximately 60 minutes and will be recorded and uploaded on the HAHIA website afterwards. Before we get started today, I wanted to run through a couple of housekeeping items. If you experience any technical difficulties throughout the duration of today's call, feel free to type them into the chat box at the bottom of your screen, and I'd be happy to assist. Everyone on the line has been muted except for our speakers in an effort to eliminate background noise. If you would like to speak aloud, please feel free to use the raise your hand function and unmute. We'll be holding all questions until the end of the session when we'll open for facilitated Q&A. I'm now going to hand things over to Jason. Jason, over to you.
Thanks so much, Chanel. Welcome, everyone. Thank you for joining us. It's a pleasure to have you here, and also wonderful to have Anne as well. Before I introduce her, I just want to share my screen for a second. So if you haven't already seen it, the International Health Economics Association website has recently been updated. It's got some nice new shiny sections. So if you haven't seen it, please have a look. I just wanted to remind the audience that there is an upcoming Congress next year in beautiful Cape Town. So if you're able to join that, and also for us, the special interest groups, specifically for today, you can see that the health preference research is one of many special interest groups that HAHIA has. So certainly have a look at that page. When you click into our health preference, you can also see other past webinars. So we will be putting Anne's webinar to be more widely available to our members. So you can click through to this link here. So without further ado, again, thank you, Anne, so much for stepping forward to share with us your DCE about melanoma. So I'll pass the time to you now. Thanks.
Thanks, Jason. Good morning, everybody. I would like to start actually by just asking the group a couple of questions. So my name's Anne Livingston. I'm a PhD candidate, nearly to be newly minted PhD. I think I've got one reviewer's comment left at the University of Sydney, but I just wanted to start with a bit of an icebreaker and just take an opportunity to use something called Menti to ask a couple of questions. So I'll share my screen now, and hopefully everybody can see that. So this requires that you, if you could sign into menti.com, so that's www.menti.com. And then once you get in there, there's a code to use. So I'm interested to see on a early morning for me, it's 8:10, with that code 7477372, what superpower would you choose? So hopefully if you can log on, and if there are technical issues, please just let me know, but I'll give you a second to log on to that website and then utilize that code. I can see people, oh, we've got a tie currently. Oh no, ability to fly, be great for getting to places that you need to quickly. However, I was thinking about this morning, the ability to read people's minds could potentially help us with grants and other funding applications, but that could also be quite scary, I think, at times. All right, we'll just give people another couple of minutes. But looks like so far the ability to fly is winning, although to be fair, on the slide, Batman's ice cream cone looks like a good option, maybe the ability to refill one's ice cream cone. All right, so that looks like the ability to fly is the most popular. So obviously speed and being able to get places quickly is the most important to this particular group. Thank you for voting. And I'll just click on to the next slide. Just give me a second to deal with the technical issues. Oh. All right, hopefully now you can see that. So this is about what's your level of experience. So there are 4 options there. I'll just give people a couple of minutes to vote. Perfect. Okay, so it looks like most of our audience are in the 5 to 10 years. I'll just give other people a couple of minutes. That's good to know. Okay, so it looks like most people are in the 5 to 10 years experience level. And obviously, as the slide says, do what you love, always important. All right, it's just a couple of questions just to try and get us a bit more awake or keep us awake, depending on which end of the world you're at. All right, thank you for that, everybody. All right, I will share my screen and pop up my presentation now. Okay, hopefully everybody can see that.
Yep.
All right. Perfect. Thanks, Jason. So as I alluded to before, my name's Anne Livingston. I am still a PhD candidate at the NHMRC Clinical Trial Centre in beautiful sunny Sydney at the University of Sydney. And thanks everybody for joining today. And I'm going to chat about what was my PhD. And this is the last project, but there were obviously a few that led up to the final DCE. So I'm going to talk specifically about preferences for adjuvant immunotherapy in respondents with resected stage 3 melanoma, and I used a DCE, which is obviously very pertinent to this particular group. And I think just to preface everything by saying that basically sorry, I'm just trying to get my slides to move on. So to preface this, obviously, I'm just making everybody on the group aware that I am a learner. I am still a PhD candidate, and I wanted to take the opportunity to present to the Brains Trust about what I have done and hopefully have some discussion around some of the things that are potential learnings from this opportunity of doing this particular methodology and using it for my PhD. So initially, I want to acknowledge that I am on the land of the Gadigal people, so in beautiful sunny Sydney in Australia, and I just want to acknowledge the traditional custodianship and law of the country on which the University of Sydney stands, and pay respects to those who have cared and continued to care for country. So for those of you that may not be that aware, but melanoma is unfortunately a very dependent on, and it's caused by UV radiation. And I am lucky enough now to call Australia home, but you'll probably take from my accent that this obviously wasn't where I was originally born. So I was born in the UK and made the decision to emigrate to Australia about 20 years ago. But the culture in Australia is such, and this is a good example on this slide, that we are a very outdoorsy country, and obviously that puts it as a greater risk from UV radiation and a greater risk of melanoma. And unfortunately, Australia and New Zealand have the highest incidence of melanoma globally. This particular slide, I think some of the people on the call are actually Australian, but for those who aren't, last month we have this City to Surf race, and as you can see here on the slide, lots of people are not particularly paying attention to the slip, slap, slop and making sure that they are relatively covered when they're exposed to the sunshine. And for some people, you can see that they actually didn't even manage to put on a shirt. So for those of you who aren't aware, melanoma actually has several stages. It goes from stage 0 down to stage 4. And as you can see on this slide, the cancer, obviously, as it progresses through to stage 4 being the more invasive cancer, progresses through the epidermis, the dermis, into the lymph glands, which we can see here in stage 3, which is the stage of melanoma that I focused on. And we can see that the cancer cells then start to spread down towards the lymph nodes, which are these little green. And then when we're getting to stage 4, that actually means that not only is it spread locally, it's also spread further around the body. And that's the same with stage 3, that it actually spreads into nearby lymph nodes. So we can see here, just to explain, that this cancer does spread through the lymph nodes. So we'll see on the left of the slide, as I look at it, that this is the lymph node system and the lymphatic system that's throughout the human body. And we can see that there are many areas where we have lymph nodes, so inguinal nodes. There are nodes in the chest, nodes in the neck. And the slide on the right hand side, we can see, which I've alluded to, which stage 3 melanoma. So that's one stage back from metastatic, where it's spread further and outside of the lymph nodes throughout the body. So the stage 3, we can see here on the diagram on the right, there's a primary tumour, and then it's actually spread to lymph nodes that are generally close by to that tumour. So that's quite typical of stage 3 melanoma. And, you know, that's quite important with regards to survival. So this particular curve, probability curve, shows us, and we can see that there are actually within stage 3 melanoma, as with a lot of cancers, there are actually substages. So we can see here that there are stage 3A, which is the least invasive melanoma, down to stage 3D, which is the most invasive. And we can see here that that's quite a significant difference with regards to 5-year survival. So if you're a stage 3A disease, least invasive disease, your 5-year survival is actually pretty good. We're getting up towards 95%. But obviously, when we get down to the stage 3D, the more invasive disease, only 1 in 3 patients will survive 5 years. So this is as per AJCC. So this is a well-known staging thing that's used basically globally to predict and manage melanoma patients. So as I alluded to, this is a disease that unfortunately the biggest incidence is in Australia and New Zealand, hence a lot of the reasoning for my PhD. It's very pertinent for where I've chosen to live in the world. But globally in 2020, nearly 60,000 people died of melanoma. And adjuvant immunotherapy, which I'll talk a little bit more about on the next slide, for resected stage 3 melanoma, like, we know that it's massively improved survival. There's been huge changes in the treatment and management of melanoma in the last decade, and this is one of those such changes. However, with every treatment, and this is a systemic treatment, so it's given intravenously, there is a potential for toxicities with any treatment. And some of the issues around immunotherapy are these potential significant lifelong toxicities. And that's to do with the mechanism that the adjuvant immunotherapy utilizes to help fight the melanoma. So an example of the lifelong toxicities you can see there is diabetes. So we can see on the left with regards to treatment, the primary treatment for melanoma of most stages, but certainly resected stage 3, is exactly that, to resect it. So melanoma, we cut it out. And then for all patients, they are irrelevant of whether they choose to have immunotherapy or not. They're all monitored and continue to be followed up clinically. They have regular skin checks, you know, scans, they'll have bloods taken, and all of that is obviously like an observation period to make sure that they have this regular follow-up and monitoring, so that, you know, the melanoma team can keep an eye on the patient's treatment. And we can see here that this is then whether the patients then make the decision to have adjuvant immunotherapy treatment or not. So again, that's systemic. It follows on and is in addition to the observation. So these particular patients in this population were their surgery to have their melanoma removed, and then they follow on and get this observation, and then they made a choice as to whether they wanted the additional immunotherapy following their surgical removal. So the aims of this, the whole PhD, but certainly the DCE work, was specifically to quantify preferences for adjuvant immunotherapy, so that additional immunotherapy, in this population of resected stage 3 melanoma. And we also, as we frequently do within DCEs, wanted to calculate those trade-offs and look at the marginal rates of substitution and their willingness to pay. So from a methods perspective, as I've alluded to, this was, you know, the DCE was the methodology, but obviously leading up to that, as part of my PhD, I did a lot of qualitative interviews with both the patients, so the respondents, and their partners who were involved in the decision-making process. So, you know, specifically looking at attributes and levels and how they made those decisions and what were the things that were important when they were making those decisions, how were they trading off. So this particular design, we used D-efficient, 12 choice tasks, 2 alternatives, which I'll talk about a little bit more in a couple of slides. There was 2 to 3 levels per attribute, and I used a couple of constraints again, which I'll discuss further in a second. And our recruitment, I was very fortunate that in a previous life, I've actually worked in melanoma and had some really good contacts. And also thank you to my primary supervisor, Rachel Morton, who's on this call, who also has some amazing contacts in melanoma. So we were very fortunate that we managed to get all of those consumer groups on board. So we can see here, this is just a snapshot of the actual DCE itself and what we were looking at. So factors or attributes on the left. So we were looking at the chance of 3-year melanoma recurrence, and then from a benefit perspective, and then from a risk perspective, things that appeared to be important to patients, and certainly both from the interviews and in the literature, were things obviously such as side effects. So mild side effects included things like fatigue, and whether they were capable of carrying out their daily activities of living. Things like an example of a permanent side effect we alluded to earlier was diabetes. So because of the way that immunotherapy actually basically works on the immune system to provide therapeutic benefit, that unfortunately one of the side effects of immunotherapy is these permanent side effects. So they're obviously irreversible, and for something like diabetes, that may mean that people need medication for the rest of their life. Another good example of a permanent side effect is the issues with hormone production. So patients, if they experience a permanent side effect, may need again medication to substitute these particular hormones for the rest of their life. Chance of fatal side effects, so things like myocarditis or pneumonitis, and they are small chances, but obviously they are a real chance that people can have those side effects and have immediate death as a result of their treatment. In Australia, we don't actually, so when I started my PhD, these particular drugs, so drugs like nivolumab and pembrolizumab, weren't actually funded in this particular population of patients. So in the adjuvant space, following surgical resection for stage 3 patients, these drugs weren't funded. During the course of my PhD in Australia, that's happened. So we were cognizant of that and wanted to just also look at the effect on patients. So this is patient out-of-pocket costs. And the dosing regimen. So these particular drugs are either given 3 or 4 weekly. And the 2 alternatives we can see there were the adjuvant immunotherapy or no adjuvant immunotherapy. And like I alluded to earlier, that's in addition to the observation. So irrelevant of whether these patients choose to have the treatment or not. Sorry, I'm just waiting for my headphones to kick back in, so hopefully now I'm back on board. So these particular drugs are either given 3 or 4 weekly via intravenous infusion. And we can see here that, as you would expect, so the chance of 3-year melanoma recurrence, we can see on this. I'm just going to take my headphones off because I'm having a few technical issues. Apologies.
So we can see here on this slide that the chance of three-year melanoma recurrence is currently 50%, and in this particular choice task, the patient or the respondent has chosen no adjuvant immunotherapy. But as we are all aware, if you make changes to your levels, so you can see here that now for the next choice task, this particular number, the chance of three-year melanoma recurrence is reduced to 42%, that perhaps that respondent may make a different decision. So methods, we've talked about the fact that all of these patients get observation, and then they were given the opportunity to choose between adjuvant immunotherapy or not. That's a normal clinical decision. And we can see here, I've just gone into a bit more detail with regards, so the attributes we've already discussed about the side effects and the recurrence and the patient out of pocket and the dosing regimen. And there's a couple of things also on the right hand side, we can see all the different levels. So as I alluded to earlier, I had 2 to 3 levels across all of the attributes. You can see the dosing regimen was just 2 levels, but all of the other 5 attributes were 3 levels for the drug treatment alternative. And in the no drug treatment, you can see that, and again, this was a discussion. We had quite a lot of discussions, but for the side effects, we came to the agreement with the supervisory team. So I had a couple of health economists that were specialists in this area and have huge expertise within DCE methodology. And I also had some clinical people who were melanoma medical oncologists, because they're quite a lot of the melanoma trials in this space with adjuvant immunotherapy. For the placebo arm, some of these patients do actually still report side effects, even though they aren't technically getting the immunotherapy. So there's an argument to do either way, but we decided that following discussion that the more sensible thing to do was to say, well, if the side effects are from the treatment and you're not getting the treatment, that maybe we should have all of those set as 0. So you can see that on the right. And the levels that are in blue were, which I alluded to earlier, were about the constraints. So with regards to the chance of 3-year recurrence, you can see that the 250s were going to be the same across both. So I put a constraint in so that then we didn't have the issue of dominance with that particular 50%. So we couldn't have both of those on the same. And then the other one that's in blue at the bottom, so the other constraint was around if you're having more frequent dosing regime. So if you were having less frequent, rather, if you were having 4 weekly drug, you are coming in less frequently for your treatment, you'd be less likely to be spending more money. So if you, the constraint was if you chose 4 weekly, then the option of the most expensive out of patient cost per year, the $6,000 value, wasn't shown basically. And then some other things that we collected for these patients, which is obviously quite typical, were some additional socio-demographic and clinical factors. So these are quite typical, I think, age, gender, whether people had children or not, education, income, substage of disease, and their treatment path to that particular point, whether they'd had immunotherapy, surgery, other treatments such as radiotherapy or no treatment. We used a mixed multinomial logit model, and as I alluded to before, that was D-efficient design. And in total, there were 13 parameters. 10 of them were random, 8 normally distributed, 2 triangular, which were around the costs, and 3 non-random. So results. I enrolled 116 patients, 53% of those, so just over half, were female, an average of 60 years, and 3/4 of them had had prior adjuvant immunotherapy. And another thing that we asked, which was interesting, was around melanoma substage. So again, we had many conversations with the clinicians about Should we ask about substage? Is this something that patients would necessarily be aware of? And I think probably this number or this percentage here speaks volumes. So we can see across those substages, so D again being the most invasive, A the least invasive disease. And you can see that the largest percentage were actually unreported. So as we thought may be the case, a significant over a quarter of the patients actually didn't know what substage they were, which, as you can imagine, has a potential flow-on effect with regards to how they're making decisions and how informed they are. And just a point again, so this kind of speaks back to that 5-year survival risk, and we can see that, you know, as we said earlier, that if you are stage 3D, potentially only 1 in 3 of these people are going to survive to 5 years. So that's, you know, it's, I suppose in some ways quite revealing that over a quarter of the patients that we recruited of this particular population didn't actually know which substage they were. So that potentially has an implication when you're trying to understand the trade-offs of the decision that you're making with regards to adjuvant immunotherapy. So again, here, this is just to kind of remind us what were the things before we look at the results. So the 6 attributes are there on the left-hand side. Recurrence was the biggest benefit or potential benefit, and then the side effects of risk and looking at out-of-patient costs and dosing regimens. So that's just to remind us before we present some more additional information with regards to results. So we can see that 2/3 of the patients in this population chose adjuvant immunotherapy. And what we found was that respondents were less likely to prefer immunotherapy. This is per 1% increase in risk of, so particularly, I've just put up the ones that were statistically significant at less than 5%. So for 3-year recurrence, we can see that, you know, that people were less likely to prefer immunotherapy if per 1% increase in the risk of 3-year recurrence. Again, statistically significant at a p-value of less than 5%. Fatal AEs was another one that people didn't really want to take. They were less likely to prefer immunotherapy if there was a perceived chance that they were going to end up with a larger likelihood that they would end up with a fatal AE, so that they would suffer immediate death as a result of their treatment. And also with the permanent AEs. So again, looking at things like, you know, thyroid or hormone gland insufficiency, and also things like such as diabetes. And we also looked at the things from a social demographic perspective, and also from some clinical factors, and the only one of the ones that we added in, so gender, age, whether they had kids, the substage, annual household income, was gender was the only one that was statistically significantly, but it was, you can see on the screen, it was quite significantly statistically significant for females, that they were 10 times less likely to prefer immunotherapy versus males with an odds ratio of 0.1. And then, as I alluded to before, we also did some marginal willingness to pay. So looking at the dollar amount, or the theoretical dollar amount that people would be willing to pay. So for each 1% reduction in their 3-year risk of their melanoma recurring per year, we split our incomes. So we gathered the information about annual household income for this population, and we had 4 income bands, and then we literally split them through the middle, which was approximately the amount of the average salary per household in Australia at the time. It was very similar where the split in the middle was. So that's approximately, or less than, about 90,000 Australian dollars, which is about 60,000 US. And we can see that they, this particular population, the lower income group, were willing to pay 794 Australian dollars per 1% reduction in their 3-year chance of their melanoma recurring per year. And for the higher income patients, as you would probably expect, that's about a 3-fold increase. So almost $2,200 per 1% reduction in their 3-year risk of their melanoma recurring per year. And those patients had a salary greater than 88,000. And then we also found, we've reported here, the reduction in the chance of a fatal AE. So like we said on the previous slide, that was one of the things that were important to patients or in this respondents in this population. So for the lower income, it was actually almost double. So people were obviously quite keen to at $1,500. So $1,500 per 1% reduction in the chance of a fatal AE per year. So they were quite keen to avoid dying immediately as a result of their adjuvant immunotherapy treatment. And with higher income, again, it was similar, that it was almost a 3-fold increase to approximately $4,300 per 1% reduction in the chance of fatal AE per year for adjuvant immunotherapy. And then with regards to the marginal rate of substitution, so with regards to trade-off, so we can see here that they were willing to accept an additional 4% chance of a permanent AE. Again, that was the things like hormone gland, you know, a reduction in the amount of hormones, or actually a cessation in the amount of hormones that these patients would make. So that might involve, for example, taking thyroxine for the rest of your life, or the diabetes is another example. So they were willing to accept, this particular population were willing to accept a 4% chance of permanent AE in order to reduce their 3-year risk of recurrence by 1%. And again, an additional, they were also willing to accept a 2% chance of their 3-year risk of their melanoma recurring to reduce the risk of fatal AE. So again, they were, you know, wanting to reduce the chance and weren't particularly keen to be dying immediately as a result of their adjuvant immunotherapy. And as I suppose the flip side, it appeared that what they were trading on was their mild adverse events, that they were quite happy to accept an increase in the likelihood of them having a mild side effect of treatment from the 1% level, which was the lowest level for mild side effects, to the highest level, which was 37% in return for adjuvant immunotherapy. And we did some subgroup analysis, and again, this is a bit hypothesis generating. It was a bit exploratory. I acknowledge that the sample sizes are very small, and we can talk a little bit more. I'd be interested to get people's thoughts about this as we get, you know, to the discussion part of this when I finish the presentation. So because obviously some of this population had made the decision to have adjuvant immunotherapy, there was a very small subgroup, so 17 patients, that had actually ceased immunotherapy due to toxicity. So usually that's a clinical decision that the risk of the toxicity is going to basically not going to be beneficial, and the benefit that you're going to gain for the treatment is not going to be good enough, then the risk is going to be too great. So that particular group of patients had a stronger preference to lower the chance of their permanent adverse events, which, you know, you would suggest that perhaps was as a result of the fact that they had actually personally experienced toxicity for this treatment and had had to cease the treatment. So we can see that that's statistically significant at the 5% level. And we can see, just as an example to show you the opposite of that, that those who had received, so we can see that this particular total, we had 92 of the 116 patients who'd received adjuvant immunotherapy, and the 17 with the toxicity, but the 75, the other remaining percentage of that 92, had received immunotherapy. They didn't cease it for toxicity, so they continued their treatment without experiencing toxicity that caused them to, or their clinical team to suggest stopping. And we can see that obviously that wasn't statistically significant. So, you know, perhaps that if you've had that experience, that you are less likely to want to repeat that again. So key messages, I think, are that, as we saw, most respondents chose adjuvant immunotherapy plus the observation versus observation without adjuvant immunotherapy. But obviously there were some, you know, particular things that drove those decisions, and especially around, as you may expect, the fact that people wanted to reduce their likelihood of their melanoma coming back. That was a huge driver, and drove most of these people's decisions. And also the other things, which is what we expected, certainly within the literature search and the interviews with patients, you know, that they were considering these trade-offs and what the risks were and how much of that risk they were willing to accept in order to have what, you know, level of benefit. And as we could see from the main results that I presented, that, you know, things like avoiding fatal AEs and avoiding permanent adverse events were important in this population. And preferences were highly influenced by the respondents' level of immunotherapy experience and also by gender. So if you were female, again, you were 10 times less likely to choose adjuvant immunotherapy than if you were male. So I just want to pop up this acknowledgement slides, and then there's a couple of things that I'd like to, if we can get the opportunity and get people's thoughts about the discussion. So thank you obviously to all of the respondents, the consumer groups, my amazing supervisory team, which Rachel Morton is on the line, all of the melanoma clinicians and clinical teams, because they gave me the opportunity to go in and pilot this DCE, make sure and actually do some think aloud methodology with patients, just to make sure that what we were asking them to do was actually reasonable and made sense to them. So I'm very grateful for all of that support, and obviously the amazing 8 consumer groups who allowed me to basically disseminated the online survey for me. I was super lucky to get several scholarships, both from the NHMRC in Australia, University of Sydney, which is obviously where I did my PhD, Sydney Catalyst, and the Melanoma Institute. That's me, their email and Twitter account. So yeah, if you want to get hold of me. And a couple of things just up on this slide for discussion, and then I'll hand over to Jason, were, you know, a couple of things that we thought about. So other types of DCE analysis. So I'd be interested to get the group's feedback. Further research, the plan is to look at, and that's certainly other areas of research within melanoma. So the big area of research that's happened in the last 4 years is actually now flipping the adjuvant immunotherapy and actually doing it prior to surgery. So that's now another population that this might be a, you know, an interesting question, and to ask about, you know, how those patients would feel. And the other thing that's happened more recently is that these types of drugs are actually being provided to earlier stage disease. So the stage 2 disease, there's just been a big pivotal trial that showed positive results and improved survival outcomes in that earlier stage disease. So 1 stage back, stage 2. And subgroup analyses, just I suppose I alluded to what people's opinions are about that. You know, I am mindful that that's really small sample sizes and hypothesis generating. And that's enough from me. Thank you everybody for listening, and I'm happy to take questions.
Thanks so much, Anne. That was really fantastic. Such an important area to research, and yeah, the DCE that you've done, I've got a few questions, but perhaps we can open it up to those who are joining us. We do have an intimate group today, but if you'd like to either pop your question in a chat box or you can also unmute yourself if you'd like to ask any questions. Whilst you're thinking, perhaps I'll start with the chair's prerogative to ask a question about presenting risks. I was curious about how people actually saw the choice sets, and you do have a few attributes where you are presenting risks to people, and I think as you know, people might interpret percentages very differently. I was wondering whether you also kind of thought around how you've presented that, whether it's a numerical version or a pictorial form. Could you talk about that?
Yeah, of course. Great question. Thanks, Jason. So yeah, there were lots of like probably most people that are using this methodology, and there is a lot in the literature. So yeah, look, I very specifically made the decision not to present percentages. I think that's different if it's a different population, but in a patient population or in a respondent population with melanoma, we actually did, I can't remember which slide it was, but one of the slides, it was like whatever the number is out of 100, and that was actually how it was written rather than a percentage. And the other thing we did, I didn't actually share that on the slide, is I used infographics. So I actually had a little square that basically had you know, little blacked out people, so that you could actually see what percentage of the square, you know, so for example, if it was 50 out of 100, half of the little people, the little infographics of the people shadow were black. So it was obvious that, or at least hopefully more obvious, that half the people were, you know, that it was showing you that half of them had that risk and half of them didn't, by the fact that they were black or white. It was also one of the things that we discussed. So I didn't talk about this just from a time perspective, but I did some think aloud discussion and did some piloting, as you would expect with best practice in this area for this methodology, with patients in the melanoma clinic, and again, patients that had resected stage 3, about how and I gave them a few options about how that information was presented. And this seemed to be the one that people favoured. So that's what we used, was the infographics, and there was obviously more text presented than what was on that slide, but I didn't want to make it too busy. And the other things that we gave people, because like I alluded to, and I think that was very poignant, the 28% of people that were unreported in the substage that actually either didn't understand the question or didn't, which I think is more likely, didn't understand, didn't actually know the answer to the question about which substage of stage 3 melanoma they were. And that was certainly the feedback from the Think Aloud, because that was another question that was asked. But we had, you know, obviously vignettes, and I also had quite a bit of information, not too much. Again, it's, you know, it's kind of hard to know where the balance is in all of this, you know, presenting the information. But we had some, you know, relatively basic information about what each of those side effects meant. So what a mild side effect was, and what that actually would, how that would affect a patient's life, rather than just medical terminology. And the same with the permanent and the fatal, because that's also hard, is whether people are actually trading off and understanding what you're asking them to do.
Great, thank you. Jackie.
Morning, hi. That was a really great presentation, Anne. I'm really interested in the finding that females were less likely to prefer adjuvant immunotherapy. Do you have any insights into why that may be?
No, that's a really good question. Look, it's interesting. There is actually some research, I don't know specifically in this population. There is actually some research in cancer saying similar, that with chemotherapy, that females are often less likely to choose treatment in similar stage cancers. And I'm just trying to recall what cancer it was. I might have a look and maybe post this later, but I think it might have been a lung cancer population where women were less likely than men to select active treatment. And I get that that's chemotherapy and not immunotherapy, and it's different. but I did find some reason. It's interesting because I actually I presented recently, and Rachel, if she's on the line, might want to comment on this, at a melanoma research retreat at the Melanoma Institute in Sydney, actually last month, and presented that finding. And there were, I mean, half of the room is melanoma clinicians, and two of their very prominent melanoma medical oncologists were asked, somebody asked and said, oh, is that what you find in the clinic? And interestingly, the answer was no, that wasn't their experience. But I have to say, again, anecdotal. I did only interview, because obviously you're limited by resource and time, as we all are. I interviewed 24 patients that had stage 3 for the qualitative stuff to try and inform the attributes and levels for the DCE. And I would say that, you know, again, only anecdotal, small numbers. I don't see as many patients as the melanoma medical oncologists at the Melanoma Institute do. But I would say that women generally, anecdotally from my discussions, were less likely to, you know, to kind of drive and have the more active treatments, that they were probably a little bit more likely, from the conversations I had and the people I interviewed, to sit back and perhaps make a slightly different decision. I don't know whether that answers your question, Jackie. I don't know whether others on the call have experience of that in any other, maybe in any other cancer or other diseases, you know, that females tend to make different decisions or perhaps choose less active treatment.
Yeah, I mean, I can weigh in. Thanks, thanks, Anne and Jason. It's interesting that I guess when you have a treatment that's, you know, potentially toxic and there can be long-term side effects, it's, you know, it's plausible that females, you know, particularly those with families, caregiver responsibilities, etc., may weigh up those downsides a little bit differently. In terms of this, you know, gender effect for, you know, aggressive treatment in other areas, there's certainly some evidence in treatments for cardiovascular disease, where women are less likely to, well, not only be offered more aggressive treatment, but less likely to prefer that line of management compared to more conservative medical management. So there could be, you know, some similarities there. One of the other side effects that the psychologists have talked about is, you know, skin rashes from immunotherapy and sort of a breakdown of the skin all over. And women in particular are quite concerned about that and the look of that, and having to then wear, you know, full length clothing, arms and legs. So that might be, you know, there may be a gender difference there in terms of, you know, wanting to avoid that particular side effect.
Yeah, very
Thanks,
interesting.
Rachel.
A similar question to Jackie is, are there other DCEs that are similar to yours? And if so, how do your results compare to those? Or are you the first to do this?
Good question. There are definitely DCEs that have similar populations. From what I could see at the time when I did my DCE, there weren't any that specifically homed in just on adjuvant immunotherapy and just specifically in the stage 3 resected disease. So there are several in the States, several in Europe that have done broader treatment. So obviously adjuvant, I didn't specifically talk about this, but in the stage 3 disease, there are other treatments. So there is adjuvant immunotherapy. And as I said, in Australia now, that is actually now reimbursed by the government. At the time I started my PhD in this stage of disease, it wasn't. There's also other additional treatments such as BRAF. So if people are BRAF positive, there's a set of drugs that they can have that are actually tablets. So some of the other DCEs had had included additional treatments rather than just specifically the adjuvant immunotherapy. And like every treatment, there are pros and cons, and they are different for each of those different treatment sets. But for me, we specifically honed in on the adjuvant. And again, I think that a lot of the American and European research in this space, so looking at melanoma and including adjuvant immunotherapy as a treatment option, included metastatic stage 4 disease, which I think is likely a different decision. You're a lot further down that pathway. I didn't show the stage 4 survival curves, but as you can imagine, they are not as good as earlier disease, as you would expect. And also that treatment is actually different. It's not single agent treatment as it is for stage 3, it's doublet treatment. So most people who have stage 4 disease are getting 2 lots of these types of drugs, and therefore will have likely significantly more toxicity. So yes, look, this is definitely, as far as I was aware at the time that I did the DCE, the only one that's looked at this particular population and specifically adjuvant immunotherapy. I am aware of another Australian health economist who did this, but actually didn't publish the results. So the results aren't available as a publication, but I did find an abstract from somebody that had done this in Australia a couple of years ago.
Yep,
so yeah,
great.
look, I think the results are different, I suppose, to answer your question, Jason, because they are in different populations with different treatments. Some of the, I think there was one of the trials, most of the trials didn't find a gender difference. So that's obviously different from what I found. But most, as you would expect, most of the trials really, certainly that included adjuvant immunotherapy, found similar things, that most people were willing to trade for those survival, or in this particular case, a reduction in their risk of recurrence, because that was kind of the potential benefit, I suppose, of my DCE. Yeah, so it's very similar.
Yeah, great. I've got a technical question about how you treated your variables that were risk related, so the continuous ones. Did you assume a linear kind of relationship, or did you also explore kind of non-linear relationships? Kind of to your discussion point about other DCE analysis. And my last thought about that is whether you also considered latent class analysis to see whether that might be helpful with your data. Thanks.
So yeah, to answer the first question, yes, most of them were linear. We did look at some of the non-linear stuff. And yes, that was kind of the reason for that first point on the discussion, because as you can imagine, and I alluded to this at the start, so I am in the process of looking at my thesis reviewers' comments. I've got one left. And that was one of the reviewers' comments, is did you consider latent class analysis? You know, we did consider it, and I suppose, you know, we didn't choose to go that way, but that is another way that you could have done it. And my question, which was the reason for that up there as a discussion, is, you know, whether others have done that, whether they've like compared the two and done latent class versus maybe the more typical, you know, mixed multinormal, and what those results look like. So it was kind of me thinking a bit outside the box about, well, we didn't do that, could we have done that, and if others have done that, what did they find the main differences were?
I do use latent class quite a lot. I mean, it's kind of nice to see clusters of kind of homogeneous preferences. And I find that often consumer groups or even policymakers, they're interested in, you know, what are the market shares of certain people who might be more in favor of immunotherapy, for instance, and what are the characteristics. So yeah, might be an interesting thing to explore. I also know that we've just ticked over to the hour. So I think with that, we might close, unless you've got any final words that you want to say, Anne.
No, other than to say thank you for the opportunity, and thanks for those that tuned in. And hopefully the people that follow the recording later will get something useful out of it.
Yeah, and thanks for also leaving your email. I'm sure that if it does generate more discussion points, they'll email you directly after they hear your webinar. So thank you again, Anne, for your time. Wishing you a good day. And
you too. Thanks,
you.
Jason. Lovely to meet you.
Nice to meet you. Bye.
Thank you. Bye.